Hey, everybody. Welcome to our podcast series on innovative healthcare solutions. If you haven't seen these are a series of interviews we do with actuaries and really other professionals that are focused on delivering innovation in healthcare. And this is sponsored by the Conference of Consulting Actuaries, or the CCA. So these sessions are really designed to, provide some insights about all the changes and exciting things that are going on in our healthcare environment today. My name's Ed Pudlowski. I'm president of Morningstar Actuarial Consulting, and I'm also chair of the healthcare community within the CCA, and I'm going to be your host for today. So I am really pleased to be joined today by Jeff Baldetti. Jeff is vice president of product strategy at Health Plan Data Solutions. Jeff, thanks for joining us here today.
Ed, it's great to be here. I appreciate you having me on the podcast and looking forward to getting into some fun conversation today.
Yeah, same here. Some really intriguing stuff that you guys do. So let's kind of
Mhm.
jump into that. So um, Health Plan Data Solutions, I think you guys go by HDS. You're
Mhm.
a data analytical partner, really kind of focused on pharmacy cost and benefits. But
Mhm.
maybe give, for benefit of our audience, maybe give them an idea of what markets you serve.
Yeah, so great question. Our primary market that we serve is really any type of healthcare payer. Specifically, we focus in, and most of our clients are either health plans, so large plans across Medicare, Medicaid, commercial, and then as well as the employer market, whether they be state or self-insured, Fortune 500 businesses. So really anyone who's paying for pharmacy benefits is a customer base that we work with.
Oh, great, great.
Mhm.
Now, again, you and I have had a chance to talk before, so I've got a little
Yeah,
familiarity with what you guys do. And so I know, you do claim scans, pharmacy analytics, and consulting, but I'd really like to start off talking about the claim scan capability. So let's talk about that first. So, how do
yeah.
your customers utilize that component of your solutions, and what value can they
Mhm.
derive from that?
Yeah, no, this is the fun part of the conversation where I get to talk a little bit about what we do differently and really why it's an important and needed part of the market. So at the core of what we do, you had mentioned at the beginning, we're a pharmacy analytics company. We support healthcare payers, but really what we do is, we call it's pharmacy payment integrity. And I think a lot of people in the audience probably familiar with medical payment integrity, but really at the end of the day, payment integrity is about making sure the right drug, the right payment was made in the right way for the right reason at the right time. So it's all about like the integrity of the actual money changing hands in the healthcare market. Specifically, what we focus on is how that happens in the pharmacy space. So making sure that claims are adjudicating accurately, correctly, and that payers are paying the right amount. So um, this is kind of similar and has been around to what a lot of people may know on the medical side, where you've got, you go to see a doctor, you get the EOB explanation of benefits. Here's what happened, who did it, at what time, and what codes we're billing you for. There's like a whole built out process on how that works on the medical side, where the payer goes in and reviews what's in that bill, is it at the right amount based on our medical booklet, and then the money changes hands. On the pharmacy side, that stuff is all instantaneous. They're pre-coded into systems by large pharmacy benefit managers so that when a patient goes to the counter, you can leave with the drug and you can get that answer instantaneously on, what should I be paying? For the longest time, there's really been very limited checks and balances into when that kind of immediate check on, what you're doing at the pharmacy counter happens, is that transaction actually going through the way that it was designed? And over the last 5 or 10 years, the complexity and cost in pharmacy as a whole has really skyrocketed. So the importance of really assessing what's happening there has become even more important. That's really where HDS, our company, sits in, is we have developed a software solution that gives payers the ability to, in real time, assess, are those transactions happening the way they should be? And if they're not, how do we go back and remedy them and make sure that the payer gets refunded, that the member gets refunded what they're owed? So a lot of stuff in there, but at the highest level, that's really what we do. And there's a lot of kind of nuance into that, but happy to talk more about that.
Yeah, and I can only imagine that requires some level of coordination between the plan design of the,
Hmm.
assuming we're talking about like a large employer, the plan design of the employer, plan design of, all the plan designs associated with the health plan, if it's a health plan.
Hmm.
But coordination between, what that plan design is, as well as kind of what that contractual relationship is between that entity and
Yeah.
the pharmacy benefit manager, right?
Yeah, exactly. It is a completely um, coordinated process that requires a real in-depth connection and understanding between the payer, between the PBM, and between our company to really make sure that that stuff is happening the way it's supposed to. And I mean, typically what we see in companies that aren't using a more real-time oversight solution
Hmm.
like ours, you're doing annual PBM audits that happen, 6 months after the plan year is closed, and you might be doing a market check, or you might be doing a really robust analysis when you go to RFP every 2 years, every 3 years, where you're really spending a lot of time and effort constructing different programs and policies that are going to help manage cost. Really what happens when we come in is like we're making sure that all of the work and effort that's been put into those RFPs is actually playing out in the day-to-day adjudication of claims. And so when we're sitting down with an employer or a plan, we're working with them to get formularies, to get utilization management records on, what types of things have PAs, what has step therapy requirements, what are all the different rates that apply to different pharmacy networks, so that we can go in and code all those nuances and configure the system so that we are recreating your benefit adjudication the same way your PBM should be. What we've found is a lot of the time when a plan goes through and does set up with their PBM, they may only be testing the system with a couple hundred claims in a couple areas. And so there are so many nuances that can fall through the cracks that most of the time people either never find, or you find them because a very specific instance happens with a member who calls and asks for help. And then that kind of triggers a follow-on effect where then there's some research that's done and you find out that a configuration was done wrong in the very beginning of the year. So to your point, it absolutely requires us working very closely with plan and the PBM to make sure that we have an accurate interpretation of what the plan design is, how it's supposed to function, and that's how we can then apply our technology-driven checks against every single one of those claims.
What I really like something that you said in there was that you can do this real time, right? So
Hmm.
you're identifying these issues as they're occurring. And,
Hmm.
my experience has been that the sooner you kind of bring those things to the attention of the claims administrator,
Hmm.
that's the opportunity for the biggest value. Now, making that correction early before other instances of that same issue kind of occur on an ongoing basis
Hmm.
really is kind of, to me, instrumental in ongoing management of your health plan.
Hmm.
And it's amazing to me too when you kind of think through that. I think most health plans would just think, oh, this is kind of what's going on anyway behind the scenes, right? And
Yeah.
and so it's amazing to me when you talked about, some of the potential issues you found and the potential savings that
Hmm.
could generate as doing that. Could you touch on that a little bit?
Yeah. Let me maybe just give a great example of this. It's an instance where the devil is in the details on a lot of how this stuff works. It's really about
You can imagine,
uniquely
yeah.
uniquely understanding how certain rules are supposed to play for certain types of plans. And to your point about catching it early, it's a critical piece of what we do. Is we think that, hey, even in the best case scenario, if you're doing a the best pharmacy benefit audit that you can do, and you find an error that happened in the prior year, in that situation, you've still essentially paid an interest-free loan of money that you shouldn't have paid.
Right.
So the example I want to talk through is there was a state that we were working with that instituted new legislature for an insulin copay cap. So members shouldn't pay more than $35 out of pocket for insulin when they go. How the law was written, there was a distinction about whether or not that calculation of $35 per month was going to be based off of a rolling 30-day calendar or actual calendar days. And what we found is that the adjudication logic with the PBM picked the wrong date version. And it was
Interesting.
inadvertently allowing, instances where members were going and potentially filling, 2 vials of insulin in the same month. They would be getting charged potentially the 2 copays and end up paying $70 instead of $35. So instances where, based on how the law was written, a patient is overpaying for the medication. We were able to flag that change in how the adjudication was happening for that plan in January of the year and stop it from happening forward. It eventually resulted in about $11,000 of copays being refunded back to the members that had been inappropriately charged their copays. But we were able to protect that from happening for the next 3 quarters of the year because we found
Hmm.
that initial error up front, able to bring it to the PBM's attention and get it remedied. And I think this is really emblematic of, like, these aren't nefarious choices. It's not being done on purpose.
Right.
Pharmacy is very complex, and these small nuances can have big impacts into what members pay, what the plans themselves are paying. And we're trying to flag them early so that we can have a really robust conversation about a couple $1,000 issue than letting this go on for months or years and having it be a couple $1 million issue.
Yeah, healthcare is extremely complex, and if you've delved into the claim administration like I have over the years, and like you guys are doing, you start to realize that these small little things then start to
Hmm.
add up. And
Yeah.
not only is it's critical to find those, but it's critical to find those earlier. And I assume that a lot of this information too that you're gathering can also be helpful to the health plan in kind of future negotiations with that vendor.
Yeah. Absolutely. I would say there are a couple of ways we help clients. One is the, black and white contract says this, what was adjudicated was different. This is a clear mistake. But others of the types of things that we start to see is whenever you're ingesting large amounts of pharmacy data, you have the ability through technology to start seeing patterns and commonalities that may not be, we like to call it may not be a mistake, like it's being done correctly based on the contract, but the interpretation of what the plan thought that was going to be doing and what is
Yeah.
actually happening might be very different. So we've seen differences in interpretation come out that end up when we're able to bring that data forward, it leads to a much more rich and robust conversation at recontracting, or even to the point of if the gap in understanding is large enough, creating mid-year amendments to make sure that the payer's intention of a specific type of program or policy is being adhered to. So
Yeah, that's a good point. And that actually I think kind of nicely leads me into a little discussion about your analytics platform. Now you
mhm,
provide an analytics platform for your customers. So
mhm,
I think based on some of the things you said, they can start to see how not only what you do can translate into looking at payment errors
mhm.
or distinctions between how the plan's being administered versus how it was contracted or understood. But now you can start to venture into what's going on within your plan and is it operating what? So it may even be issues of how plan design is creating some issues that you may not have thought were going to be possible. So, but can you talk a little bit about your analytics platform
Yeah.
and what value that brings to your customers?
Yeah, exactly. So we already talked a little bit about the ongoing monitoring part, which is ingesting. Normally, we have claims that are coming in every 2 weeks with the normal invoice cycle, and we're reviewing those and providing, is this happening according to the contract or not? We already have all that pharmacy data coming in, so we do operate more of an analytics suite that's looking a lot more about not, are the claims themselves adjudicating correctly? In those situations, we're looking a lot more about, like, how is the pharmacy benefit being spent? What are your trends looking like in specialty versus traditional? Let's dig down into specialty. How are your spend between drugs that have biosimilar options versus reference product options working? What does your GLP-1 spend look like? So we've developed a lot of dashboards and reports that allow you to dig in and ask a lot of questions of the pharmacy data and get some answers into why your trend might be higher than expected from last year, lower than expected. Is it being driven in certain areas? Um, so a lot of it is around more of those kind of qualitative, like what is actually being spent in our benefit and how is that impacting PMPM, total cost, rebates, things like that. And we have tried very hard to integrate elements of the ongoing monitoring process into that analytics suite. So there are certain types of, I would say, routine claims issues that we see that we've developed pre-built reports that specifically assess. So a great example is a common error that we might find is on compound drugs, pharmacies always submitting the maximum level of effort applicable for that highest amount of additional dispensing fee, even if that highest level of effort may not be warranted on the type of drug that's being dispensed to the member. So we have a specific pre-built scan that's going to look for all drugs that are compounds and looking at those level of efforts. And that is like a very discrete opportunity that can be brought to a plan to say, hey, here's an area where the system can be kind of played with to your disadvantage. Here's what we're seeing in your data. Let's have a conversation about this. And that may then lead to a conversation with the PBM about more protections and how compound drugs are processed or changes to that logic. So we try very hard to give discrete actionable opportunities for plans to really assess where can we make improvements and tighten the performance of the pharmacy benefit.
Yeah, and this has to be critically important, particularly in this time when we think about how drug costs are growing at an annual rate greater than even the medical component, which that's growing at 2 to 3 times that of general
Right.
inflation. But on the pharmacy side of it, particularly you mentioned the GLP-1s, which those are the drugs that were originally meant to help individuals with diabetes reduce their risk associated with that chronic condition. But now, they're being used for weight loss. And I just recently learned too that the GLP-1s now are being used for just people with cardiovascular disease, even if they're not suffering from diabetes or overweight. They're being used for premenopause and perimenopause patients. And so the expansion of those, maybe can you talk a little bit about kind of what you're seeing in that space and maybe what the plan's reactions to that based on a lot of the data that you're providing them?
Yeah, it's a great question. If I was going to think of like the short list of topics you end up talking about with almost any healthcare payer, it's going to be GLP-1s, it's going to be biosimilars, and it's going to be rebates are probably the three
It's
areas. Maybe cell and
GLP-1s
gene therapy.
yeah. Sorry, GLP-1s have just been dominating the discussion, particularly among actuaries and benefits consultants. So I
Yeah.
didn't mean to interrupt you
No,
there.
it's a great area to talk about because I mean these are expensive drugs. They're typically not considered specialty, but they're still very expensive. They are in a lot of cases maintenance drugs that people are on for long periods of time, and the population base that can be prescribed them is massive. I mean, at a minimum, we're talking about the diabetic population, but if you expand that in the U.S. to the population that could be, for cardiovascular or weight loss issues, like it is a large amount of people, and so it's very clear why it's on everyone's mind. So a couple of the things that we look at, we actually have a specific dashboard that's built out that looks at diabetes drugs and specifically has a focus on weight loss versus diabetic medications, where we look at GLP-1 usage for the plan. So part of that is about helping plans understand how is our usage of these drugs, if they cover them for both diabetes or weight loss, changing over time. And I think a really cool piece of functionality that we specifically look at is we calculate persistency rates. Because one of the biggest things that I think is important for plans to see is these are expensive drugs, but a lot of times the side effects are pretty serious. And so people might not be on them for long periods of time. And what we have found is there are also sometimes lax protocols on how people can get refills of GLP-1s or brand hop from one manufacturer to another, where you end up in situations where people can have a lot of supply of GLP-1s that are very expensive that they may then fall off and not take because of the side effects. So we help plans see, people that were prescribed this drug 30 days ago, how many of those people are still on this drug? And then how does that change after 60 days, after 90 days, after 365? So you can start to see and have more information around, how should we be thinking about covering these drugs if 50% of the people that start taking them are no longer taking them within 30 days or 60 days? Like maybe there's something else we should be talking about with our PBM about how do we better manage who gets access to these, how we support them to make sure that they're getting the best adherence or staying on that therapy. So those are just a couple of things that we look at, and we try and balance out, how much of your diabetes spend is going specifically to these drugs versus your insulins, your metformins, so that we have a better understanding of how that's driving your overall cost. But
Yeah, I think you've done a great job of giving our audience at least an understanding of how your analytical platform can help out. And we
Mhm.
talked about the market scan. The other thing I wanted to touch on was your repricing capabilities, because we talked about
Yeah.
this before, and it was pretty intriguing to me how you can go out and look at some of the other pharmacy options that exist out there, like the kind of cost plus company, Mark
Mhm.
Cuban's company, and they talk a little bit about how you can kind of take customers' data and
Mhm.
kind of look at those options and give them a sense for what that might mean for them.
Yeah. No, that's a great question. And I think what's interesting about it is there are so many new innovations in how you can, impact prescription drug pricing in your plan, whether they be Mark Cuban's Cost Plus program. You've got Cost Plus programs coming from the big three PBMs now themselves. You've got Amazon. There are so many of these options that I think a common question that we see from payers, period, is, should I even consider this? How would this impact my plan? And so, how we approach this is we already have the underlying claims data. And in most of those cases, whether we're talking about, Mark Cuban or Amazon, the APIs that list what price those drugs that they have access to should be priced at on a certain date are publicly available. And so what
Hmm.
we can do is we can create a canned report for our clients where we take claims that have been processed over a certain time period, and essentially we add in that cost plus pricing logic and essentially rerun those claims as if that had been part of the plan design from the beginning, and can show essentially, hey, if we took your raw claims over a certain time period and they added up to, you spent $10 million. Let's now take those same claims and reprocess them as if you had Mark Cuban as one of your pricing options in place, and re-adjudicate those claims with that logic built into your lesser of, and see what that number is. Is it, 9.5 million? Is it $11 million? Just to kind of give a little bit more direction of, should we be incorporating this type of pricing uh, design or not? Is it even worth entertaining with, our consultant or our PBM? Now there are always nuances to this because in most of the cases you've got rebates to play into this, and so that is a challenge. As I'm sure the entire audience knows, the pitfalls with rebates about they come in after the fact. A lot of times you don't have an idea of how big they're going to
Right.
be, but at least what we're trying to do with these reprices is give directional guidance on, it potentially could be a big difference either positively or negatively. And we've actually found with a lot of clients that even if the answer is this wouldn't be beneficial to the plan, that's a really valuable data point, because we've seen with the much more targeted focus from government, from regulation on, why aren't plans implementing these cost plus programs or cutting out the traditional model. This gives you a data point to say we've assessed, would this be beneficial to our membership? And the answer is the math says no. And I think that's a perfectly acceptable solution that I think plans are wanting to be able to have if it's the case for them.
Yeah. Right, Jeff, we've talked a bit about the claim scan and the data
Mhm.
analytics and kind of repricing. Is there anything I didn't touch on that you wanted to let our audience know
Um,
about?
That's a good question. I think the only area we probably haven't gone through, it's more of a nuance with the ongoing monitoring, but I think an area that we do work with a lot of clients on is embedded in a lot of the algorithms that we have that assess whether claims are processing appropriately. We also have a lot built in there around regulatory compliance and fraud, waste, and abuse. And so beyond just making sure, hey, the drugs on certain formulary tiers are getting charged the right copays and people are getting the right drugs, we're also looking at pretty, I would say, important compliance measures like, are prescriptions being filled after an expiration date, or are, class 2 narcotic drugs being allowed to get refills when they shouldn't be able to. So
Okay.
there are a lot of, I would say, important fraud, waste, and abuse or regulatory pieces that we look at so that plans know that they're being protected from a third party that's unbiased. So a lot of the times the PBM may have these types of programs, But we want to make sure that there's an extra check for the plan so that they feel very comfortable that, we're doing our due diligence on fraud, waste, and abuse. We have a third party checking it. We want to make sure we're in regulatory compliance with the states that we operate in or the federal government, like we talked about earlier with that insulin copay issue. Those are things that I think we're seeing, especially with some of like the ERISA-based lawsuits. Like these are real risks for employers, for plans, that we want to be able to provide them extra support and confidence that they have someone looking out for them in their best interest.
Great, great. Well, thanks for sharing that. Now,
Mhm.
I want to take this interview in a little different direction here, and this is something I do with a lot of my interviews. So, Jeff, if you weren't vice president of market strategy, if you weren't in the healthcare space, if you were doing, that thing that you would love to do, what would you be doing?
Oh, that's a great question. I'm probably going to take this in a different question, in a different direction than most of your guests. So, um, I played golf in college. Love playing golf. So if there was a way that I could get paid to play golf for a living, that'd probably be it. I don't know if I'd want to be like a PGA professional because it's a hard life and there's a lot of travel. But I mean, there's not much better than getting to play a new golf course with some architectural significance and being outside. So um, that'd probably be where I'd go.
Great. Well, knowing that you said that, if we ever get a chance to golf, I'll make sure not to wager in any bets with you based on how bad I
Exactly.
play.
I've taken away any hustling opportunity from myself. Yeah.
Yeah. Well, thank you for the interview today. I'd like to really encourage our viewers who, participate in healthcare community to, continue discussions around much of the insights we shared here today. And if you're listening to this and you're not a member, I'd encourage you to consider joining, because not only do you get the benefit of that community that I mentioned, but there are many number of other great benefits that members of the CCA enjoy. So Jeff, thanks for being here today and sharing your insights and experiences, around a lot of the value that Health Plan Data Solutions brings, and the innovation that you guys are driving in the field of healthcare. I know I thoroughly enjoyed this conversation. I'm sure our audience did as well.
Yeah, likewise, Ed. Thanks for having me on. It was a great conversation. Looking forward to any of the conversations that come out of this from the membership. So, any questions you all have, we'd love to hear them.
Great. Thank you.
Thank you.